صباح الخير. Good morning. Good morning for all. We will start immediately at 11. So we have like 3 minutes to start presentation now. So I see that is great that people are joining now.
مرحبا دكتور.
مرحبا حنان، كيف الحال؟
كيفك؟ شو الأخبار؟ تمام؟
الحمد لله.
أهلا حنان.
مرحبا، كيف الحال؟ شو أخبارك؟
الحمد لله الحمد لله.
أهلا بكم.
السلام عليكم. وبنتكلم عربي والشباب كله عربي ما شاء الله.
عليكم السلام. أهلا وسهلا.
إحنا رح نعمل محاضرة في الإنجليزي لأنه في شباب من تركيا وفي شباب من سريلانكا.
Yeah, we will talk in English. The language or the presentation will be totally in English. So, because this is a real international webinar, and we have a lot of participants from different countries. In front of me in the menu, I can see that we have around something like 8 countries. So we are really now in international webinar, so the preferred language will be the English. Now we have 1 minute, and at 10, I will mute all the participants. I will mute all the participants. I will start the presentation, and after the presentation, we can then unmute all and talk to each other if the time allows for that, of course.
Yes, and I recommend every people okay to close their video that we secure the connectivity of the internet.
Yeah, that's also better, because if we have a lot of video conferencing, this will affect your appearance or presentation.
Yes, the other point that you can open the chat icon if you have a question or any comment, so you can write it in the chat icon ونتواصل. تمام؟ أنا هلا راح أقفل الفيديو.
I will mute all, and for anything we can keep connecting. Hanan, if you have anything, we can keep connecting by phone. Okay, I'll mute all participants. Yes, mute all, and now we will start. So great, really it's a great pleasure to find you all and prepare for this international webinar. I'm happy to see all of you here in this webinar, and in fact we will start now, and if you have any question you can ask later. Our webinar is about hearing estimation for children with delayed speech. I'm Haidar Sarhan, Assistant Professor of College of Medicine, Muslim University, Baghdad, Iraq. And it is my pleasure today to talk to all of you in this international webinar. So, the rules of this international webinar will be like that. I already mute all the participants. I already mute all the audience. If you have any question during this seminar, you can just write your email and write the question in the chat menu. Why? Because we want to preserve time. We have 40-minute time limit for the presentation, and we want to preserve the time. Also, for any other audience who, for example, any other audience that doesn't have a question, but he wants to know the answers of the questions of other audience, he can also put email address in the chat. So according to the time limitation, if I have time, I will answer questions during the webinar, question by question. If I don't have time, I will send one email to all email group for all answers of all the questions. And according to the time limitation, if after answering the questions in the chat room, if we have time, I can unmute all the participants and we can talk to each other. So that's the way that we will go for our presentation. Just a minute. Hanan, can you see the presentation on your laptop, on your video? Is it clear?
Yes, I can see it.
Okay, that's fine. So now, delayed speech. It is dilemma of delayed speech because we are usually facing children that they have either autism or hyperkinetic child, and he has delayed speech. Whether this child has autism or hyperkinetic versus hearing loss. And this is really a dilemma, and we usually face such a problem in our everyday clinical practice. Because we are working in a close contact with the pediatric clinic, a very famous pediatrician that he is dealing with autism, with delayed speech. You want to know the hearing level for all those patients. So usually sends patients to us, and we're doing a hearing test and give the pediatrician the report. So very important point to keep in our mind that mild hearing loss in children is usually missed by the parents. And there is a visual cycle between the hearing loss and hyperkinetism. What that means? That means that child with mild hearing loss, usually the parents miss the situation of hearing loss, and the child will be presented with delayed speech and hyperkinetism state. And according to that, hearing test is very critical step in the subsequent management of that child. That's, for example, if we have a child with that has a mild hearing loss, and we did the hearing test, and we send a report that this patient has normal hearing, the pediatrician will go for management or as a spectrum of autism or as a hyperkinetic child. And in that case, he will start to give medications. Medications will bring side effects to the child, and some of the side effects may affect hearing. Also, the side effects of medications may lead to hearing loss as well. So hearing test is very critical. Hearing test is very critical step of management of that child. It will change the future life of that child. Also, another thing that I want to figure out. I want to figure out the psychological threshold versus electrophysiological threshold. Now, psychological threshold is the threshold that the child just feels when hear the sound. While electrophysiological threshold is the threshold being detected by a device which depends on normal physiology of hearing of human being. So the typical example for psychological threshold in adult is pure tone audiometry, while in children, Path Medical wrote very nice integrated module of magic module, that is play audiometry. The child will play a game and the examiner will get very nice threshold of hearing. And the electrophysiological threshold is very well known. It is ASSR, ABR, and otoacoustic emissions. Now, very important things that also I want to highlight is the new classification of hearing loss. I want to highlight very clearly that the hearing in children is better than the hearing in adults, that the child of 2 years of age definitely hears better than me and you. We are adults, so the children hears better than us. So accordingly, the new classification of hearing loss, that normal hearing in children is minus 10 to 15 decibel, slight hearing loss 16 to 25, mild hearing loss 26 to 40. Accordingly, when we have ABR with wave 5 detected at 30, this is not normal hearing, because I saw a lot of reports from a lot of operators that they get wave 5 at 35 or 30, and that's okay, this is normal hearing child. No, definitely with 30, this is a mild slight or mild hearing loss. And we'll come across that. And this is another privilege of using the PATH Centero device, because really from my 15 years experience of doing these tests, it is with other devices from other manufacturers, it is really challenging. It is really difficult to get wave 5 in a threshold below 30 decibel. While with PATH Centero, you can get wave 5 even with 5 decibels, so clearly without any problem. Another things that we want to cross over. Accordingly, let's show some example case by case. Case 1, we have 3 years child presented with delayed speech. Parents mention no any history of hearing loss, any signs or symptoms of hearing loss of that child. And when we perform the test, this is a screening test of transient evoked acoustic emission, showing the left side showing past. And this is the right side also past. This is the transient evoked autoacoustic emission, distortion product autoacoustic emission, left side past.
تعالي من عندك عشان انا عملت له سايلنت معاه.
Right side is also passed, and as you can see, wave 5 detected at 10 decibel on the right side and at 10 decibel on left side. So accordingly, what we have up to this level, we have past screening test of autoacoustic emissions and normal ABR. Is this a normal hearing? If you have only these modules in your device, you will mention in your report that this is normal hearing. But again, if you have another facilities in your device, you can see what's happening, what's going on. I will show you. As you can see, I performed to that child distortion product autoacoustic emission threshold test, and it shows low and mid frequency drop, and in the right side as well. So accordingly, this child has not a normal hearing. This child has abnormal hearing, has slight hearing loss, has low and mid frequency drop shown by distortion product threshold detection test. This is very great module. Accordingly, if you have only one module available in your hand, you will miss cases of slight and mild hearing loss. Otherwise, if you have fully equipped with a lot of modules, you can perform different tests, and you can be sure about the report that you send about the state of hearing of that child. Also, very important point that you should keep in your mind: you should never ever depend on one module, on one test for detection of threshold. At least you have to fix and confirm the threshold of hearing by 2 tests, by 2 modules. So that's the message from that case. Let's go to another case. Now, before that, I have now just a minute, because okay, we have people just waiting. I want to admit them. Okay. Now, very important note that distortion product threshold detection test gives cochlear threshold, while ABR is a neural threshold. What's that? Because we know very well that state of sensory neural hearing loss, we have 3 types of hearing loss: conductive, mixed, and sensory neural. What's sensory neural? It is defect in the hearing end organ, which is the cochlea, and or defect in the neural connection of the cochlea. So accordingly, distortion product threshold test is the cochlear threshold, while ABR is the neural threshold. Accordingly, let's see this case. Case number 2, 1 year and 2 months child presented with hearing loss. You can see I perform ABR, chirp ABR, and there is no wave up to 90 decibel. And when I perform distortion product threshold detection test, it is normal in all frequency level. So this is a case of auditory neuropathy. Accordingly, if you have only ABR in your system, you will, if you have only ABR in your system, you will diagnose this case wrongly as a case of profound hearing loss. And if you have only the distortion product threshold detection test, you will diagnose this case wrongly as normal hearing. If you have all the modules, you can reach the correct diagnosis of auditory neuropathy. So this is auditory neuropathy. The cochlea is normal, while the neural connection has a deficit, and the condition is called auditory neuropathy. Case number 3. 2 years child presented with delayed speech, no parent sign or history or symptoms of hearing loss at all. When I performed the hearing test, the clinics test of distortion product.
دكتور الصوت عم بيقطع، صار لك تقريبا دقيقة عم تحكي، الصوت مش واضح أبدا. بس لو تعيد قبل دقيقة.
نرجع للموديول مثلا.
Yes, if we start, yes, from, yeah. No, not from case 2.
From case 2. Case 2. Now the voice is okay, Hannah?
Yeah, the sound is okay, yeah.
Okay.
Yes.
1 year and 2 month child presented with hearing loss. I perform ABR, chirp ABR, and there was no wave at up to 90 decibel. And I perform distortion product threshold test. It was normal hearing in all frequencies. It is normal hearing in all frequencies. Accordingly, this child has auditory neuropathy. If you have only ABR in your system, you will diagnose this case wrongly as profound hearing loss. And if you have only the distortion product autoacoustic emission threshold module, you will diagnose this case wrongly as normal hearing. If you have all the modules, you can reach the correct diagnosis of auditory neuropathy. Case number 3, 2 years child presented with delayed speech, no parent history of hearing loss. Accordingly, distortion product autoacoustic emission screening test showing refer on the right side. And also it was referred on the left side. And also the transient autoacoustic emission was referred on the right side and was also referred on the left side. When I did ABR, wave 5 detected at 25 decibels, so on the right side. So this is, accordingly, this is mild hearing loss. And it is also 25 on the left side, mild hearing loss. When I did tympanometry, it is a flat type P, so there is high suspicion of middle ear fusion. How we can confirm that? How we can confirm the presence of conductive hearing loss rather than sensorineural hearing loss? I performed for that case, I performed bone conducting APR. If you see transducer is 71. Okay, Hanan. I performed bone conduction ABR because we have time limit. I want to cover all the subject of presentation. I perform bone conduction ABR, and as you can see, the transducer is B71, which means bone conduction, and the wave was detected at 15 decibel. And on the internet is unstable. On the right, on the left side, also B71 bone conduction, the wave 5 being detected at 15 decibel. So accordingly, we have bone conduction at 15 decibel, air conduction at 25 decibel, air bone gap airborne gap 10 decibel. So this is conductive hearing loss, and this is middle ear fusion. This is otitis medial diffusion. And by that, with bone conduction ABR, we can confirm the presence of conductive hearing loss. If you don't have bone conduction ABR, you will never ever be able to confirm the presence of middle ear problem. You will never ever be able to confirm the presence of airborne gap. You will never ever be able to measure the airborne gap. Now, with the bone conduction ABR, airborne gap is measured correctly, and as all of us know that airborne gap, when it is 10 decibel or more, this is significant. This is conductive hearing loss, and the case was otitis media diffusion, which is the most common cause of conductive hearing loss in children. Again, let's go to case number 4. Let's go to case number 4. We have a 4-year-old child with history of hearing loss. That now we have 4 years age child. 4 years is like, how to say, old enough to perform psychological threshold test, to perform play audiometry. Accordingly, we decide to perform MAGIC, and with MAGIC we receive this output. We receive that this child has like slight hearing loss, and this is against the history of parents. The parents bring the child and they say that this child has hearing loss. So this is something which is confusing. And to confirm, we perform the screening test, and as you can see with the screening test, transient evoked autoacoustic emission, it was referred on the left side and passed on the right side. Accordingly, I performed the distortion product screening test, was also referred on the right side and passed on the left side. Then, when I perform,
Doctor, can the participant please? Yeah, can the participant please close their microphones? You can mute yourself, please. Mr. Muhammad Aqil, please mute your microphone. We can hear you.
I mute all, Hannah. I mute all the participants. Okay. Returning back to this case, I will repeat the findings of that case. This case is 4 years of age with play audiometry MAGIC module. We get slight hearing loss on both sides, and then refer screening test of transient acoustic emission for the left side, refer and pass for the right side. The distortion product autoacoustic emission was also referred on the left side and passed on the right side. And when I perform distortion product threshold detection test, I get the findings that this child has mild to moderate hearing loss. So accordingly, this case was moderate hearing loss. It is important to confirm the psychological threshold when the results are suspicious and when the cooperation of the child with the test is not perfect. So electrophysiological test is needed here to confirm the threshold. What we should do? We should do ABR or distortion product threshold detection test. Of course, ABR needs sedation, and this is 4 years of age of child, and it is difficult to sedate such a child. When we go to distortion product threshold detection test, we can perform the test without sedation, and for PATH, they integrate very nice a game that aircraft flying in a farm, and that makes the child just concentrate on the airplane while the test is going on and the threshold being detected. And accordingly, I decide to go to distortion product threshold detection test because I don't need to go for sedation for that child, for that older child. And I confirm the threshold of moderate hearing loss for that child. Okay. Let's go to another example. So accordingly, after all of these examples, what are the parameters to confirm the normal hearing of a child? What we should do to be more than 100% sure that this child has normal hearing. We should get past screening test of distortion product acoustic emission. We should have past screening test of transient evoked acoustic emission. We have to have wave 5 detected at 20 decibel or better, 20, 15, 10, because the child has hearing better than adult. We have to have also normal impedance curve, normal tympanometry. Of course, normal tympanometry, impedance curve is very important. Also, we should have normal frequency specific hearing threshold, like distortion product, autoacoustic emission threshold test, or low or high chirps. And I'll show you an example. This example shows this child has normal distortion product threshold text in the right side for all frequencies, and for the left side for all frequencies normal. And it's the screening test of the distortion product autoacoustic emission were passed for the right side and passed for the left side. And also the screening test of transient evoked autoacoustic emission was passed from the right side and passed also for the left side. And also wave 5 being detected at 15 decibel, where the threshold chirp ABR threshold was 15 decibel, which is great. And also for the left side, it is 15 decibel also. Here, this is very important note. I want to figure out, I want to highlight, this is very important. Why it is important to repeat the cycle of the threshold. What that means? That means when you are doing ABR and you get wave 5 at 20, and then go for 15 and get wave 5 at 15, and then go for 10 decibel and get wave 5 at 10 decibel, then go for 5 decibel, I don't get wave 5. What you should do, it is not correct to say that the threshold is 10 decibel. You should repeat the cycle of 10 decibel, and you get 2 cycles of 10 decibel with the same waveform morphology. As you can see here, it is the same waveform morphology. Waveform morphology for 2 cycles are just identical. And also you get the time latency for wave 5 for both cycles are also identical. At that case, you are more than sure that this wave 5 being detected because it is threshold of hearing rather than it is a chance factor, rather than it is an artifact. And you can be more than confirm the threshold of hearing at 10 decibel. And I will return back to the right side also. As you can see on the right side is just the wave 5 being detected, the threshold at 15 decibel. Also, the morphology is just the same. And the time intensity of wave 5 being detected is just the same. So this is the threshold and this is wave 5, not by chance, not by artifact, because it is wave 5 by threshold. Okay. So you should repeat the cycle of threshold. When you get the last intensity, the least intensity, when you get wave 5, it should be repeated to confirm the same morphology, to confirm the same time intensity of the occurrence of wave 5. At that time, you will be more than confirmed that this is threshold of hearing. Now, very important is what to keep home message, because now all of us doing business from home, and I hope that all of you are safe from this coronavirus. So keep home message. All of us are now in home, and what messages that you should keep with you when you are now in home. First message: it is not. Don't depend on screening test to confirm normal hearing of a child. For example, if you have the screening test of distortion product or transitive or autoacoustic emission and you get pass, this is not normal hearing, because we know very well mild hearing loss may show pass, slight hearing loss definitely will show pass with screening test. So don't depend on screening test to confirm normal threshold of hearing of a children. The second message, that slight or mild hearing loss is usually missed by the parents, that those children usually presented with delayed speech rather than with hearing loss. Those children may present it with hyperkinetic state rather than with hearing loss. Third message, a good percentage of patients, of children with autism have also coexisting hearing deficit. This is very crucial. This is very important. Why? Because I know a lot of pediatricians, they think that this child has autism, and because autism or spectrum of autism, this child has delayed speech. But the researchers prove that a good percentage of children, a good percentage of children with autism, they have coexisting hearing loss, whether sensory or cognitive hearing loss. Accordingly, if we want this child to learn speech, we should treat both two conditions, the hearing loss and the autistic problem as well. Okay. The third message, that mild degree of hearing loss usually lost by usually presented by delayed speech with hyperkinetic state. That's the vicious cycle that I told you. That this child has mild hearing loss, and the parent doesn't recognize the degree of hearing loss and start to be hyperkinetic child, and then they go to pediatrician and say our child is hyperkinetic. And if we don't perform a hearing test and go for medication of hyperkinesism, this is a big problem. So it is very crucial to perform hearing tests for all those categories of children. The first message is that it is needed to have more than one electrophysiological test to confirm the threshold of hearing in children, whether normal or abnormal. This is also important. Again, I want to repeat that you cannot depend on only one test to confirm the threshold. You need to have at least two tests. The last, but of course it is not the least message, that frequency-specific modules needed to confirm the hearing is normal in all frequency range, because when we perform CE chirp or chirp, which is the threshold of hearing of all the average threshold of hearing of all frequency spectrum show normal. That's not enough, because we may have some drop of frequencies in one or two of the frequency range, and this also may affect hearing. So you should perform frequency-specific tests to confirm that this child has normal hearing in all frequency range. And stay home, stay safe. Hope all of you and your family are safe from coronavirus, and return back to your normal life, to very nice life that we get before this pandemic problem. Return back to normal, to our normal life, hopefully very soon. Now I will open chat and I will try to answer. Let's see. I'm waiting. It seems that there is no question. Okay. If anyone wants to ask, you can open the mic. Can I have a presentation on email? Yes, you can. You will have the presentation. You will have the presentation on YouTube, on website of Bath. I don't know. Depends on Hanan. Hanan will manage for that. Anyway, I can put the presentation on YouTube. If anyone has, thanks for your attendance also. Hanan mentioned she will send this presentation to be sent to all. And anyone have a question, he can open the mic. Now I can open the mic for all also. I can open the mic for all the participants, and for all the participants, if they have any question, anyone have any question, feel free to ask. Anyone have any question?
عليكم السلام.
And
بدنا
I'm so
3
happy,
جبنة
I'm so happy to
موزاريلا مع
all of
العكاوي
us people
وتنتين
from different countries of the world.
عكاوي يعني
It's a
موزاريلا.
nice opportunity. Anyone have any
جيب
question?
موزاريلا مع
Just ask
العكاوي.
please.
مخلوطين مع بعض وتنتين زعتر.
الميكروفونات فجأة قال لهم بفتح الميكروفونات.
Seems that there is no question. Up to now, I finished my presentation. If you want to repeat anything from presentation, I'm ready. Thanks a lot for all. Hope to see you again. Hanan, is there anything else should I present? Hanan?
Doctor, they have 2 questions. What about ASR and its role in diagnosis hearing loss? And there is a question from Saudi Arabia about what type of frequency specific test.
Sorry,
In the chat,
repeat it, please.
Can you please mute all again?
Okay.
Because people. What about ASSR and its role in diagnosis of hearing loss? And what type of frequency specific test?
Hanan, open your mic, please.
Yes, I open it.
Okay. So
You have a question?
The role of ISSR. The question is the role of ISSR. In fact, ISSR is very great test when you want to perform for patient with severe to profound hearing loss. For patient with normal hearing or mild hearing loss, I don't prefer to do it. I have also published research about this subject in Pan-Arab Advanced Audio Vestibular Journal of Audio Vestibulogy. You can go for this magazine and you can download this research for free. Usually it gives the wrong estimation. Usually with ASSR you will get wrong estimation. At this very long time, you can perform 2 to 3 other tests with the time of performing ASSR. So keep ASSR for severe to profound hearing loss and use other tests for normal or mild hearing loss. Don't use ASSR. Yes, Hanan.
The other question is what type of frequency specific test? This is from Saudi Arabia, from our distributor.
Okay. What is the preferred test, the frequency specific test for child with normal and or slight mild hearing loss? Is that the question, Hanan?
Yes, doctor.
Okay. So you need to perform distortion product autoacoustic emission threshold detection test. This is the test because you have different types. You can perform rapid test, you can test frequency, high frequency, and other tests you can perform is frequency specific ABR. Also, there is a module of frequency specific curve. You can perform high chirp and low chirp, and you can compare the high frequency with the low frequency. These 2 tests are the preferred frequency specific test to be performed for the child with suspicion of slight or mild hearing loss versus normal hearing. Yes, Hanan.
Yes, doctor. This is the 2 main questions I have found in the chat lately.
Okay. So if no other question, I can.
Hello.
Sorry.
Hello.
Yes.
Hello. السلام عليكم. السلام عليكم.
عليكم السلام.
دكتور حيدر شلونك زين إن شاء الله.
أهلا ومرحبا.
I thank you about this nice presentation. I